welcome to HSMP 5525. This course is one of the concentration courses for those who are in the MPH, and it's one of the courses that is required for the certificate. So we have a mixture, predominantly in our online group. I think everyone here in class is in the MPH, but our students who are online are a mix between those who are in the MPH and those who are in the certificate. So those who are in the MPH will most likely know me. I'm trying to make sure this is okay. This is not going up and down, but hopefully it's loud enough. You guys will know me from last semester. My name is Dr. Kate Beatty. I am an assistant professor in the College of Public Health in the Department of Health Services Management and Policy. This is my 5th year at ETSU, and therefore the 5th year that I'm teaching this course. I teach this course with my esteemed colleague, Mr. Ryan Youngblood, and he will introduce himself in a second. For those who don't know me, I do research primarily in the areas of rural health and rural health disparities and public health systems, but I'm part of a really large grant that is evaluating a statewide women's contraceptive access program. And so when I'm not in the classroom, I'm spending my time doing research on those topics. When I'm not at work, I am a wife and a mom of 2 kids and 2 dogs, and we live just down the street and are very invested in Johnson City and love being here. When I interviewed here, one of the things that drew me to this area was the fact that the College of Public Health does a lot of community-based work. So you'll see a lot of your faculty are doing work in the community, and that was really important to me for my research. I think that's really it. I have an open door policy. So any of you guys can come by my office, and anyone can call my office at any time. I'm usually there. Or we can set up, WebEx, Zoom, whatever you want, if you want to meet online. Okay, I'll turn it over to Mr. Youngblood.
And that's so I can see you guys. So I'm in my 6th year, I think. Mm-hmm. I've been in Johnson City area for about going on 6 years. My wife and I have 4 kids. We moved here 6 years ago from Little Rock, Arkansas. But we were in Little Rock I was there for 14 months. They were there for 12 exactly. We moved in Memorial Day weekend and moved out Memorial Day weekend the following year. That was enough time in Arkansas. Previous to that, we were in Chattanooga for 4 years and Birmingham, Alabama for 5.5, and then we're from the Atlanta area, so we're kind of all over. We have anyway. I ended up here before. I didn't end up here to come teach. I'm the Director of Quality and Risk Management at Quillen Rehabilitation Hospital. I've been in that position for just over 4 years. Previous to that, I was the administrator for Princeton Transitional Care. That's what I was hired from Arkansas to come in and do. And so I was in that for a little over a year. And then they went through a merger with Signature Healthcare, and Quillen went through a merger with Health South, which is now Encompass Health. I, at that time, had my oldest was in his senior year, and he had been in 3 high schools in 3 years. And the CEO of Quillen had his office right next to mine. We split the hospital right down the middle. We had 34 beds and they had 26. And so when the merger was occurring, he walked next door to my office and said, "Hey, so how would you feel about making a change?" I'd been in long-term care and skilled nursing at that point for about 5.5, 6 years, and had decided that that's where I was going to be, right? And I said, I don't know. I'd have to talk to my wife. Knowing some of the traditions of some of these skilled nursing conglomerates, some of their MOs are that they like to bring in the newly acquired facility and keep the administrator on for about 6-7 months, get their people acclimated, and then bring in a newly hired AIT or someone who's been with the company for just a short amount of time to save cost. And I'd seen that happen in the last 7 or 8 acquisitions with that company, and I decided that I didn't know that I wanted to put my kids through another move and have to pick up roots. You know, we liked the area, and so I went home and told my wife I was taking a new job. He had offered me the same office, same pay, so it was kind of a no-brainer. I've been in. I'm not your traditional healthcare executive. I'm more of a hybrid. My undergraduate degree is in, of all things, molecular biology. My master's degree is in healthcare administration. But I spent 9 years as a regional marketing director for a cabinet hardware company. That's a long story how I got into that, but short end of it is that I was the only individual in the company who spoke Spanish, and just kind of worked my way through without a degree. Saw that I needed a degree, decided I want to make some changes, ended up with the molecular biology degree, and then was laid off, found myself looking for a position, and ended up moving into the world of finance, because biology and finance are so closely related. So I worked as a financial analyst and controller for a company by the name of Alstom. They make high-speed rail and nuclear turbines, and I worked in their turbine division, and I did that for close to 4 years. So, you know, that's a long story, but I ended up in healthcare after that, and that's where I am, and that's what I enjoy. And how does it all apply? You get a whole semester to figure it out, because I'm still working on that. I have an open door policy, but it's not on site. My office is at Quillen. I do call me anytime you have questions. If you want to come talk, come by. If I can't, if you would rather talk here, call me. I'll make an arrangement to come here and meet up with you. Well, I'll just reserve one of the conference rooms and we can meet up. Hobbies.
You're a runner.
I used to run a lot more. I hurt my knee this past winter, and I'm old, and so you hurt a knee, you're in trouble. But that's what my family does. My kids run, so I try to keep up. And I was a cyclist in college, and that's it. Pretty boring otherwise. So, got any questions? Just shout. I'm pretty open-minded. I'm not a doctor. I like to make that prevalent. I have not put in that kind of work. Okay, so if you call me doctor, I'll just kind of remind you, Dr. Beatty's the doctor. So.
And I'm not that kind of doctor. Don't show me any moles. Don't show me anything.
No, I don't. That doesn't bother me. But please don't show me moles either.
Okay, so the way we kind of set up our course is that when we started this, Mr. Youngblood and I looked at all the topics that are covered in this course, and we picked our top and favorite ones. So we will be taking turns leading the class in different weeks. I've made a little video. I apologize for any poor quality. I use a different computer than I usually do because I left the other one at home. But this short video goes through how the syllabus is set up in the D2L, so we don't have to take too much time today to go over it, but we can talk about anything as it comes up. You will see, if you're familiar with the course that I've taught in the fall, we have checklists every week. We have quizzes every week. We had 10 homework assignments, and we now only have 5. So we kind of narrowed it down to our favorite and the ones we thought were your favorites. So you're welcome. And we're welcome too, because we don't have to grade all the homework. Any questions about the course? I'm sure you'll have some as we continue and move on in the class. One thing I'll get off, say up front, there's no group work in this class. There is a big project, and we'll talk about it a little bit more, but that is a project that you pick your own topic, you research a topic that's near and dear to your heart, you do a interview, key informant interview with someone who has the job that you want to have in that area, but it's all you, and you don't have to work in a group for it. So that's one thing that I think students like after being in my class previously.
Can I add to that?
Huh? Yeah.
I have been asked in the past as kind of last resort as an interview. I don't take offense to being the last resort, but at the same time, that is a source for you. But know that if you ask me, I get to grade this as well. So, you ask me the questions, I remember what you said, so keep that in mind. So.
Okay, any questions before we jump right in? Okay. All right, so this week we're going to talk about an overview of the U.S. healthcare delivery. For you guys, you will probably see every week we put the learning objectives at the front that we're going to cover. Those are in our syllabus. We're a competency-based program, so we make sure that we hit those every week. So, when we talk about the U.S. healthcare delivery system, I think the first thing that comes to mind is just how complicated this quote-unquote system is. It is not one entity, it's not one unit, it is made up of multiple different components. So the broad definition of the U.S. healthcare delivery, our health services delivery system, is that it's the major components of the system and the processes that enable people to receive health care. When we think of like more of a restrictive kind of definition, it's the act of providing health care to patients. And this can be in different settings, and we'll talk about the different settings and all of that throughout the semester. But the primary objectives of a health system is to enable all citizens access to the services which are needed, and to deliver those services at a cost-effective level to meet pre-established quality standards. So universal access, cost, and quality, what do those sound like? Go way back in last semester when we talked about the three main objectives of what? It starts with an A.
ACA.
Mm-hmm. Yeah, so the ACA was to increase access, lower cost, and increase quality. So those weren't things that the Affordable Care Act made up. Those are the things that are really a basic primary objective of any healthcare system. So when we talk about the U.S. healthcare system, we're going to talk about some different descriptions and things about it. So it's unique. I think many people from around the world think of the U.S. as having the best healthcare system in the world. But like I said, it's not a universal, it's not a system. There's no universal healthcare that's paid for by taxes that we see in other ones. No other country operates like the U.S. And we have a lot of critical issues that relate to those three things of cost, access, and quality. So when we think about the numbers, and these are probably old, so you don't need to memorize the exact numbers, but where do most people get their insurance from? Employer, yes. And we'll talk about the history next week. Mr. Youngblood will go into the history of the public health system, and really where this comes from our original employer-based insurance, dates way back. The next two big areas or providers are who? Start with M's. Medicare and Medicaid. And we'll delve really deep into both of those this semester. So Medicaid has over 6 million recipients, and Medicare has over 40 million beneficiaries. And then everyone else either has some sort of other public insurance or is uninsured. And so that number of uninsured kind of oscillates every year, and it's been changing. We were going down for a really long time, but it's slowly going back up. So those are the different types of insurance. So why do we have people who are uninsured in this country?
They can't afford it.
Can't afford it. So we have the largest portion of the pie is from private employers, but not everybody's insurance or everyone's employers provide insurance, right? There's a lot of qualifications. You have to be full-time for some companies. The company has to be a certain size to require it to provide health insurance. Even if the company provides it, some people might not take advantage of it because it's just too expensive, the out-of-pocket costs, right? So those are some reasons. Even if every American were insured, would we still have uninsured people in the U.S.? Yeah, because we have people who are not Americans here, right? We have people who would not qualify for any of the benefits. So when you guys watch, either here or at home, we still haven't decided, Sick Around the World, you'll see some of the reasons why the U.S. healthcare is such a behemoth, and why it costs so much compared to other countries. And unlike what we think of a system like a well-oiled machine, there are a lot of issues with the public health or the U.S. health system. So there's a lot of issues around little or no networking. There's issues with standardization. We're working towards coordination of care and planning and direction. So there's lots of siloed care, siloed components that don't all work in the most efficient way. But I would be remiss if I did not talk about all the great things about the U.S. healthcare system. The reason people across the world think of the U.S. as the best healthcare system in the world is because we lead in some really important areas. We have the best medical technology. We have the best medical schools in the world. We have the best, most innovative research as well. And our system is very sophisticated. And so there's a lot to be proud of about our system and why people want to come to the U.S. to receive medical care, want to come to the U.S. for their medical training, and to work in the medical field. But there's these external forces that affect that healthcare system. So, as a public health systems research, I like systems, I like different kinds of figures that kind of illustrate things, and so this is one of many that you'll get to see in this class. But let's start with one that I think, from the U.S. perspective, since 2016, we've seen just how, I guess you would say since 2008, we've seen the importance of the political climate in healthcare. Because what happened in 2008? Who was elected? Obama. And he ran on this idea of reforming healthcare. And by 2010, we had the Affordable Care Act. Fast forward to 2015, 2015 during the election, there was a lot of pushback in those 5 years against the Affordable Care Act for many, many reasons, including how it got passed only on party lines. And so there's been this call, this battle cry to repeal and replace. And our current president, that was one of his main platforms. And so I guess it's now 3 years ago, we came in 2016, we're like, okay, what's going to happen in this class? Do you have to throw out the whole Affordable Care Act part? We're going to have to learn new things on the fly. But we've seen how the political climate can impact healthcare. The economy can impact it. Both the general economy, when we have recessions, impacts it, and then when we think about how this system is partially on a free market, or it's a market-based, there's competition that impacts it. Technology impacts our healthcare system. One of the things that drives up cost is technology. In part, our love for technology. The physical environment, those kind of more basic public health kind of things we think of. The population characteristics. And so this is both on a macro and a micro level. So from a system of the public health system, or the healthcare system, sorry, I keep saying public health, healthcare system nationally, but within regions, within a system like Ballad, the characteristics of the population that you are serving impacts it. Global influences, and then the social values and culture. So the culture of your community, things around kind of the social cohesion, the ethnic diversity, those all impact healthcare delivery in this country. Okay. We've already kind of talked through most of this in detail, but we'll talk a little bit about the characteristics of the public health systems that differentiate it in the U.S. So in most developed countries, they have some sort of national health care program where citizens are entitled to receive a set of services, and this controls costs through what we call global budgets to determine the total health care expenditures. So in the United States, we don't have this kind of system. So in those systems, the government usually controls the frequency of healthcare services, especially when it is something kind of more expensive. And so we'll hear about this more in the video that you watch for homework this week. But in the U.S., it's a mostly private financing and delivery. So it's a pretty much like a 55-45 split between financing privately through employers and through government. And so no one really monitors the total expenses or costs through global budgets or utilization. So we don't really have those set controls on our system. And so we also only have partial access. We don't have universal access in the United States because we don't have health care that's available to all citizens. And then when we define access, access is the ability to obtain health care when needed. So access in the United States is restricted to those who either have insurance through their employers, are covered through some sort of entitlement or government health care plan, can afford to pay out of pocket, or can pay at time of service privately. So really, access equals insurance in the United States. We also have an imperfect market. So what makes our market imperfect? So when you go to the doctor, do you know how much it costs? You're not alone. Like, if it was really driven by a market, by a free market, you or I would be able to look and say, okay, say you're going to look for a car. You would look at things you want in a car. You would compare the prices of different models, different makes, and you would make a decision based on multiple pieces of evidence. And cost comes into it. And so you'll see that can lower costs. Say, you know, the Ford and the Chevy dealership are across the street from each other, and there's a discount going on in the Ford. You'll see some discounts going on at the Chevy dealership. We don't have that. There's a lot of things behind, behind the curtains. It's only partially managed by free markets where the patients, so that is us, the buyers, and the providers act independently. So that would be in a market. And that prices would be set by interactions of supply and demand. And patients would have information available on different services. So we don't see a price breakdown until you ask for it. We'll go into that later. But so we don't really have a true market. There are a lot of intermediaries and third-party insurers. So we have patients as your first party, providers as your second, and the intermediaries, which are your third party, fall between those and the finance and delivery. They're like our middlemen. There's multiple payers, we know this, and that can be cumbersome. When we start talking about the financing side, really the administrative burden of having different payers with different sets of services that they will pay for, different price points, that all gets very complicated and is cumbersome. And then when we talk about power balancing, so with those multiple players between the patients, the providers, the insurance companies, this all, and the employers who would play a role, and not to forget government. These all kind of are fragmented by their own self-interest, right? So it prevents any one entity from dominating. So in countries that have a universal system, the domination is by the government. But we don't have that, like one entity dominating it. When we talk about legal risks, and this is something when you do your homework, you might start to see the U.S. and Americans were very litigious. And what do I mean by that?
Litigate a lot?
Like to sue. I mean, just think of the hot coffees at McDonald's, slippery floor, what have you. It's something about us is very litigious. But because of that, practitioners, out of self-preservation, often will have to engage in defensive medicine. So they'll prescribe more diagnostic tests. They'll run more checkups. They'll do all this documentation just in case. But all of that adds up to more cost. One thing I didn't realize until I talked to Dr. Corey. So Dr. Corey is married to an OBGYN who works out in Kingsport. And we were talking one day, and she said that it's very expensive malpractice insurance for an OBGYN because the window of time when you can sue is 18 years. So you can have a baby and within 18 years decide that something may be the fault of that OBGYN. And that is a long window, right? And so that adds cost because of that insurance that they have to carry. Let's see. Technology. How many of you have a smartphone? How many of you have like a iPad or a something? How many of you have like Google Home or something? Okay, yeah. So I can raise my hand to most of those. We are, a hotbed of research and innovation. But that creates demand for new services despite the high costs. And there are, again, these legal risks against providers denying new technology. So even if technology is only making a small improvement, we like the newest, shiniest thing. We want our hospitals to have these new wards that are super high tech. When I have a 7.5-month-old, and there are 2 hospitals in this town to deliver babies at, and I've had the opportunity to deliver a baby at each one. And one is right next to the children's hospital, so it has the best place if you have a high-risk pregnancy to go. The other one has the fancy delivery suite area. And so I can say the services were the same. Like, I had very similar experiences. I liked both. But my husband, when we were looking at the services of the other hospital, they had Wi-Fi in the room, You could watch your Netflix on the TV. I mean, these were all the things that were really important to him. And he was really jazzed that we were going to that one for the second one. So those are the things that, again, add cost. The care is the same. But would you want to go to the hospital with the newest MRI machine or the biggest, cardiac, what have you? That technology drives up cost. So new service settings along the continuum. So when we think of medical services, they have three broad areas: curative, restorative, and preventative. And those can happen in many different settings now. And care is no longer confined to a hospital. We'll talk a lot about the shift from inpatient to outpatient care. That has happened in not too long of a time frame. Just a shift in how hospitals have to think about how they do their work. And then the last piece is this quest for quality. A lot more of the metrics now that hospitals and the healthcare system are being judged on are related to quality. And Mr. Youngblood, as what was your fancy title?
I don't know, they got a new one every week. Quality director.
Quality director. He'll talk a lot about that later on this semester. Another little shout out to Mr. Youngblood is that I think every semester you have a student from either the undergraduate program or the graduate program, or both. 4. So it's a great place to do your field experiences with Mr. Youngblood. Okay, so we're going to talk about the quad of the functional model. Is this something that you guys are familiar with? Have you guys heard about this previously? Here is another graphic for you to look at. So the 4 components of a healthcare delivery are finance, insurance, delivery, and payment. So financing is to buy insurance or to pay for healthcare services that are usually, again, paid for by employers, but then we also have our government and self-funding. So that's your financing side. Insurance, which was originally for just catastrophic care, protect against catastrophic risk. But your insurance package determines what you are eligible to receive. So it lists the things that you are covered and are not covered. Now, if it's not covered, you can still get it, but then you're now a self-payer. The delivery is our providers, and so those are any entity that delivers healthcare services and receives insurance payment directly for those services. So when we look at this, you see insurance gives you access to those providers directly. And then payment is the reimbursement for those services. And it's the determination of how much you pay. These funds come from the premiums that we pay to our insurance companies. We typically pay co-pays, and then the insurance company pays the remainder. And this can look different if you're an insured patient or an uninsured. The price for a service is not fixed. So these are, so then when you think about this, the insurance, and I'll move over here so I'm not in your way, risk underwriting. What do we mean by risk underwriting? Talked a little bit about this last semester. So a lot of insurance companies will give you a discount if you do what? Get a biometric screening, fill out some survey about your behaviors. Why do they want that information? Yeah, know if you're healthy. But it helps them better predict how much you guys are going to cost. Like if you guys were a company, we could better predict and underwrite the cost. And so that directly leads to capitation and discounts. And what is capitation? Mr. Youngblood, what is capitation?
Sorry, I'm responding to a work text. I didn't hear what you were.
What is capitation?
What is capitation? Gosh, so that's like, how to explain this? It's fees that you pay basically up front, and it allows you to set the amount of services. Is that the easiest way to define that?
So you have your underwriting that helps you identify how much it's going to cost. You have your capitation and discounts. These are things that are negotiated between the insurance company and the providers. And they are very much related to the underwriting because you're looking at your pool of risk and deciding what it's going to most likely cost you. And then based on that, there's utilization controls. So what are these? What are controls, utilization controls? I'll give you a good example. So when I first started at ETSU, I still have the same Blue Cross Blue Shield of Tennessee for Tennessee employees. It's great insurance. When I moved here, and for the first couple years, the coverage for chiropractic care cost me a copay of $25. And with that, I could also get a massage. So for $25, I could get an adjustment and a sports medicine massage. That is the deal. Do you think I took full advantage of that? Yeah. And apparently a lot of people did. Because after a couple years, you could get the appointment but not the massage. And then a couple years later, the appointment costs went up. So there are things that you'll see those things change based on what's costing the insurance company too much money. Very sad that they changed that, but why did they change that? What is something we talk about that may have led to me overutilizing that service? I wouldn't say I overutilized it. I utilized it just enough. Moral hazard. Do you guys remember that from last semester? So there was very low moral hazard, so I just used it. So they started making it more expensive. Do you think I get as many massages now? No. Very few now. Okay. So we've gone over the major players. I don't think we need to bemoan that too much. So insurance and health reform. So the two main public health insurance programs are Medicare, which is for our elderly Americans, some disabled, and that is fully administered by the federal government. Medicaid is for indigent, and that is co-managed and administered and funded by the state and federal government. And so for your first case for this class, you're going to kind of dive a little bit into what this looks like between states that, through the Affordable Care Act, expanded Medicaid beyond the traditional level, and those states that did not. Some healthcare reform. The Affordable Care Act was signed in 2010. It created marketplaces. And last year, we saw a shrinkage of plans in the marketplaces, an increase in premiums paid. This year, there were expansion in some cases, but almost across the board, premiums went down. And so the marketplace, what is the marketplace? What does it provide for people?
Affordable insurance.
Yeah, so there are plans for individuals who do not get their insurance through one of those other either public or private insurance through their employers. And the marketplace takes advantage of multiple people in a risk pool. They're negotiated at the state level or within states. And they allow, again, for individuals to find affordable insurance. And many individuals are able to apply for subsidies and things like that based on their income. They might not be able to, they may not be considered indigent, so they don't get Medicaid, but they do have income that is below certain levels that allow them to get some subsidies. And then we always have our uninsured who don't have any public or private insurance. Managed care, we're going to talk a lot about that this semester. And how it's kind of evolved over time. So we won't belabor this. We have a whole week on managed care. But something to think about when we talk about access. And this comes up a lot when we talk about, well, people have insurance, so they obviously have access. Is that entirely true? Is having insurance the golden ticket? No, I see heads shaking no. Why is that?
You could have an extremely high deductible or something like that that still prohibits you from utilizing it in most cases.
Yeah, so you could have a high deductible that the amount you have to pay out of pocket before you really see the insurance kind of taking over some of that cost be too high for individuals. So high deductibles. What else?
High copays.
High copays. Yeah. So again, my chiropractic visit went from $25 to $45. It doesn't seem like a lot, but that's almost double. And you know, certain services that are specialists are more expensive than you know, general practitioners, family medicine, and complex patients who are sick see a lot of specialists, so that it can cost a lot of money. What else? So we'll talk a more about rural maldistribution of physicians and limited access. But one thing that limits individuals is case mix. So if you're in an area with very few physicians, physicians or providers get more money from, what do you think, private or government insurance? Who do you think pays more, private or government?
Probably government.
Private. The government, though more people get their health insurance through their employer, the government, you have to think of that not necessarily as an employer, but as a very large entity that has a lot of power when it comes to negotiating pricing. And so the government pays less than private. So, and providers often complain that they pay less than what it costs them to provide a service. So, they have to be careful about managing their case mix. If you have too many patients that are covered by insurance that pays less, your margins get really thin. So in some areas, yes, there's physicians, but the waiting time for someone with a government insurance may be 2 months. They may not be taking you the patient. They may be maxed out at the patients for a certain insurance type. And so just because they have that insurance doesn't mean they actually can see a provider. And when we talk about enablement barriers, what would that be? Think about the things related to social determinants of health. What may enable or make it difficult for someone? What could be a barrier for someone to have access? Beyond cost. We've already talked about cost. Transportation. Yeah. What else?
You said they could live in like a rural area.
Yeah. And in some places, I have a friend who lives in Hancock County, and she was pregnant at the same time as me when I was pregnant with my first child. And her options were either to go to Knoxville or Morristown or all the way over to Johnson City to deliver her baby. That's a long way to travel when you're about to give birth. Versus me, I had access like 5-10 minutes to hospitals. And it was a straight shoot. It wasn't through the hollers and up and down and all around. So geography. Hours of operation. You know, if you have a job that you don't accrue sick time or vacation time, getting off during the day means you don't get paid. And if that's the only time a facility is open, that's a barrier for you. There's cultural barriers, medical mistrust. There's all kinds of different things that affect our access beyond just having insurance. So insurance is not, again, that golden ticket. If we gave everyone insurance, all of a sudden everyone in the United States would be healthy. It's not how it works. Okay, so we talked about this imperfect market. So this shows you your supply and demand curves. And right here where they meet, I'm not an economist, this is not my area, is where the market determined equilibrium is, where the supply and the demand meet, and you have your price and quality. This would be under free market conditions, which we don't have, as I mentioned. We don't know necessarily the price, and sometimes we aren't really sure about quality. So we don't make choices based on the market. Oh, wrong direction. Okay, so we're gonna hear more about these different insurance plans, but there's three main universal or national systems. And so the national health insurance is government finances the health insurance through taxes. So your insurance is through the government, but the care is provided by private providers. So everyone is covered by insurance that the government provides, and it is funded through taxes on individuals. And so Canada is an example of this type. A national health system is one where tax helps finance it, but the government is more involved in the infrastructure of the delivery. It operates the medical institutions, and then the providers are government employees or organized through the government. So national healthcare system, a national healthcare system, think of that as it's all government run. I think that would pass the American test. Government run, government paid, government run, government employed? No. And then the last is socialized health insurance. So this is financed through government mandated contributions by employers and employees. The health care is delivered by private providers, and the insurance and payment are closely integrated, and the government exercises overall control. And so some examples are Germany, Japan, and Israel. And so in the video, they do a really good job of illustrating the difference between these. And so the way that national health care programs control costs are through global budgets and allocation of resources. Global budgets are determine the national health care expenditure. So those are set that this is how much we're going to spend on health care this year as country A. And often, very much in line with that, there's an allocation of resources to ensure that we stay within that global budget. So the availability of services are closely controlled, and the reimbursement levels. So these are the two main ways. So in these national health care programs, there may be services that are not available because they are cosmetic or not considered necessary. The amount that providers get reimbursed is decided based on those global budgets. And do they have a lot of say? You either get reimbursed by the government or you don't have a job. So there is a lot of control that's in there. And so there's a lot of lack of control by the providers and a lot of control by the government. One of my favorite parts of the movie is when a doctor in Japan is talking about, they have a book that tells them the price of everything, including stitches for, a 1-inch cut is the same cost in rural Japan as it is in, capital, Tokyo. In Tokyo, the same cost no matter where you're at. And they have a book that tells them the exact cost they charge for everything. So that's like serious control. So when we think about all this kind of overview, what's important for you all as you kind of think about who you're going to be one day as healthcare managers is since Mr. Youngblood and I have been doing this, there have been many, many changes to the healthcare system. Change is the norm. So being able to understand change, take advantage of the opportunities and minimize the threats. And then one of the things that is exciting and maybe scary for you all is that there are changes happening even more rapidly than ever before. And so you're going to leave here in a time where employers are going to expect you to understand some of the new regulations, understand some of the new financing models, and be able to understand the impact on new regulations. Because those new regulations, you get held to those standards, right, Mr. Youngblood?
You do, whether you want to or not.
All right. So, we'll kind of move on to kind of the next piece, which talks more about kind of the beliefs and values that shape our delivery of healthcare services. Let's see, we've been at it for about an hour. Do you guys want to take a break and stretch? Okay, we'll take a 5-minute break, stretch, and we'll come back. All right. So we're moving kind of on to beliefs, values, and health. And so we know that resources are scarce. And so because of that, we have to make decisions about how much healthcare should be produced and how that healthcare should be distributed. And the distribution creates inequities. Those that are the haves, and those that are the have-nots. And so there is a need for justice and fairness. And we're going to talk a little bit about different types of justice. The two main we're going to talk about are market and social justice. And so when we talk about, to kind of like go over equitable distribution of healthcare, so the principles behind market justice are that healthcare is an economic good that's governed by free market forces and supply and demand. It believes that individuals are responsible for their own achievements, and that people make rational choices in their decision to buy healthcare products and services. People will consult their physicians who know what's best for them, and that the market is best and works best without interference from the government. So there's an association with the classical ethical theory, and so when we think about that in the context of healthcare, is that physicians are duty bound to do whatever is necessary to restore patients' health, and the individual under the classical ethical theory is responsible for paying the physician for those services. So the physician is duty bound to provide the service. The individual is bound and ethically responsible for paying for that service. Those who cannot pay for it, so the poor, are served by charity. One of the things about the classical ethical theory is that it ignores it ignores societal good and people's responsibility to community at large. So it's very much on that individual level and doesn't really take into society. As far as its association with libertarianism, is that equity is achieved when resources are distributed according to merit. And healthcare is distributed according to minimal standards and financed through a willingness to pay. And that healthcare is not really a central priority. So it's a market good, not the central piece. And so from a market justice perspective, the production of healthcare is determined by how much the consumer is willing and able to buy at the prevailing price. Those not able to pay have barriers to healthcare, and there's rationing based on their ability to pay. So in the market justice perspective, who would be winners? Who are the winners?
Wealthy.
Those who can pay. Those who can pay are the winners. So the flip side, who are the losers?
The poor.
The poor, yeah. So this really is a focus on the individual rather than the collective responsibility for health. And so we hear a lot of arguments for market justice when talking about repeal and replace. You'll hear things about, why should I have to pay for women's health, visits, women's care? I'm a man, personally, but there's this idea of I should only be paying for what I am using. And there is, some compelling arguments for that. So the other kind of side of the coin, our other way of looking at and of justice and fairness is the social justice perspective, where it's the good society instead of a market good, or an economic good, excuse me. And so this theory is at odds with capitalism and market justice. The equitable distribution of health care is society's responsibility. It's best when a central agency is responsible for the production and distribution of health care. And so health care is considered a social good and should be collectively financed and available to every citizen. Some of the principles that underline social justice is that healthcare should be based on need rather than cost. There's a shared responsibility for health, that there are factors outside of an individual or person's control that might have brought on a condition, that there is an obligation to a collective good, that the well-being of the community is superior to the that of the individual, and that the market, or that the government rather than the market can better decide. And through planning, they can decide how to distribute services among all citizens. So for social justice, who are the winners?
Wouldn't everybody be a winner?
Everyone's a winner.
I mean, I
I mean, that's what someone who comes from a social justice perspective would say. Everyone is a winner, right? But those who were left out of a market or an economic market, free market system in a social justice, they are a winner. They are now have a seat at the table or have the same access as those who have the financial means for services. So who might be losers in this case? Thinking of it from that perspective.
People that originally could afford to pay for it.
Yeah. So now they may have to wait longer to get a service because now everybody can get that service. We hear about long wait lines in countries that have some sort of national healthcare system that, you know, those who have the means now are on the same playing field as those without means. So they may see themselves as losers. But Braden, you see that everyone are winners. So I can see where you fall. Okay. So this is from your book. I like kind of how they show it, but you cannot see it very well on this slide. So if you guys want to look and compare market justice versus social justice, table 2-5 has this, and it kind of goes through what I've already described. So if you didn't take the vigorous notes as I spoke, you can look here. So what is health? There are many, many different definitions of health. One is the absence of illness and disease, or a return to an illness-free or disease-free state after an episode. Another is to promote, restore, and maintain health. But there are different definitions of health. We have one that is at the front of our building right when you come in, which is from the WHO, which is a very holistic definition of health. It's beyond just absence of illness and disease. So when we think about health, the U.S. healthcare system has followed what we call a medical or biomedical model, which is looking at from that disease model. So the existence of a disease or illness, a clinical diagnosis, and a medical intervention. So there's this idea of the Pearson's sick role. Pearson was a functionalist sociologist, and I won't go into too much of this, but this stuff gets me really jazzed. This whole kind of theory or idea of the sick role. But what he argued was that when someone is sick, means the sufferer enters a role of sanctioned deviance. So a person who is sick is allowed by society to leave their daily obligations. And we think about this as if you have the flu, you should stay home, right? Society tells you that you need to leave your regular obligations, but by society telling you that you need to leave your regular obligations and get well, that is your main focus in that sick role, is to do the things necessary to become well again. So our right is to leave those obligations, those normal social roles, and it also says that we're not necessarily responsible for a condition. But the obligations when you're in that sick role are to get well, and that includes seeking care from a competent medical professional. And then once you're well, you join back into society as a whole. So we see this play out again in this medical or biomedical model. So this biomedical model governs how the U.S. has a concept of health and healthcare. It plays out in that there's this existence of an illness or disease. There is that individual who has this seeks out care and uses care. They find relief and comfort. They are then restored. So now you go from a state of illness and disease back to an illness, a state of disease-free. And then once that person is well, they're considered cured. But there's some other concepts related to health that are more encompassing, especially for those of us who are in a program in a college of public health and getting a master's of public health. So we'll talk more about those factors. So when we talk about illness versus disease, so illness is often defined as our personal, like how we evaluate how we're feeling. People who are ill are considered ill when they have diminished capacity to perform tasks and roles. So that's when they're sick, like that sick role. A disease is based on a professional evaluation and can be caused by more than a single factor. But that is, a disease has been evaluated by a professional. When we talk about the epidemiology model, some of you might remember this from FE, or this might be new to you, but the triad, or the three parts, are the host, the agent, and the environment. Does that ring a bell to you guys? And so the host is the organism, and in the case of what we talk about, it's the human. For the host to be ill, the agent has to be present, and the agent is either like an illness like the flu, tobacco, smoke, a poor diet, but it's something that will make someone ill. And the environment can either enhance or reduce the disease. When we talk about risk factors are attributes that increase the likelihood of developing a disease or a negative health condition. So when we think of that within that epi model, if the host, things that an environment that might, or risk factors that might increase the likelihood of someone being sick. What are some things about an individual that might increase their likelihood of being developing a disease? What's a risk factor? What are person level risk factors? Vaccinations. Would that be so that might be one. Okay, what's another? So vaccination. So what does vaccinations mean? Like you're keeping up with things you need to do, right? What else can increase your likelihood of getting disease? Smoking. So like your behaviors. Yeah. What else?
Genes.
Yeah, your genes. There's some people who, no matter how hard they fight it, they just have a genetic disposition for heart disease or for certain kinds of cancers. Yeah. So agent, again, this is something that presence of it has to be there for someone to become ill. So you might have the genetic predisposition, but the tobacco smoke, so secondhand smoke, poor diet might be one. And then environment. What falls into the environment? These are things outside of the host that increase the likelihood. What are some environmental risk factors? We've gotten rid of a lot of them in the U.S., but they're still out there.
Unclean air.
Unclean air quality. What else? Lead in your water, poor sanitation, environmental neighborhood characteristics. And so prevention is really interventions that counteract those risk factors. So they're hitting at the risk factors to impact your likelihood of disease. Another thing that is really important is quality of life, which is your overall satisfaction with life. So it's not only just being alive, right? You can be alive and have a very low quality of life, and so we look at quality of life as a very important indicator, because we don't want people just barely getting by, but we want people to have full whole lives. So when we think about things that determine health, like I mentioned, if everybody in the United States was given insurance and everybody had really good medical care, that only would impact about 10% of premature deaths in the United States. Your genes, about 20%. Your environment, about the same 20%. What is the biggest piece of this pie?
Behavior.
Our behaviors, right? So there's a lot that we do or don't do that have an impact and lead to premature death. And so we talk a lot about determinants of health in the college, but this is a figure that shows you kind of those determinants of health and how they impact the distribution of health and well-being. So we have these social, economic, and political contexts. Those are those big macro things that impact our health. Then in that smaller purple, those are the things that we often think about as your social determinants of health. Your education, your income, your occupation, your gender, ethnicity, and race, that all have an impact in your social position. And then those all interact and are impacted by the healthcare system. They all, again, are impact. So as healthcare kind of evolves beyond just looking at their things that happen within their four walls, a lot of it is around the determinants of health, especially those external contexts, because those, again, have a bigger impact on the likelihood of someone being healthy and their well-being. And as the healthcare system is now being more is being held accountable for health, that becomes more important, and we're seeing more around population health, more around continuum of care, wraparound services for people, because we understand now that there are a lot of things that impact people's health beyond just good medical care. And so moving from an illness, disease model to a wellness model, the focus is on prevention of disease and optimizing well-being. And so we look at this when we think about those levels of prevention. What are primary level preventions? Primary prevention. Mm-hmm. So a vaccination would prevent a disease from occurring. So primary prevention is keeping a disease from ever happening. So vaccinations are a great example. What would fall under secondary? Screenings. So why does screenings fall into secondary and not primary? You're right, but why?
Yeah, I'm trying to remember.
Isn't it to see if you have the disease so to catch it early?
Yeah, catch it early. So early identification of disease. So before it's manifested itself and caused disability, what we call morbidities around it. So screenings are a good example of secondary. Now what is tertiary?
That's like preventing further complications once you already are experiencing the main effects of the disease.
So you already have type 2 diabetes, but you are trying to manage it. Or, in some cases, lessen your A1C to a state of not being diabetic, maybe being pre-diabetic. Or you already have cardiovascular disease, but you're trying to prevent a major episode from occurring. So, the definition of health that we have in the front of our building is to fulfill society's interest in assuring conditions which make people healthy. No, that's not. That's the IOM. That's the WHO is the one that we have, which has well-being in it. So I apologize. But this idea of it's society interest in assuring the conditions. And so when we think about public health role, we always think about prevention. So that's what we've already kind of talked about, with a focus more on primary and secondary prevention. Health promotion, and then health protection. And so health protection is kind of where public health, when we see the governmental role of public health. So this is becoming less and less of a clear distinction. Medicine includes this battery of different individuals. We'll talk more about the workforce, the healthcare workforce in a couple weeks. Public health is the same as above, all those, except we add in addition kind of the more traditional public health workforce: sanitation, epidemiologists, hygienists, food and drug inspectors, environmental health specialists, all the things that we think about that go beyond the individual but are more at the society or our population. So when we think about the well-being paradigm, do we have this? Yes, so here is our Bloom's field and well-being paradigm of health. So this, in the middle, this should look very familiar as the determinants of health, where we start with the circle that's the closest to us, at the individual, and each concentric circle goes broader all the way out to society at large. So when we think about environment, we're talking about the physical environment, that's the easiest one to think about, but also the social and cultural and economic environment. When we go a circle in, we see society, and that is where we live, work, and play. So that has a major impact. Further in, we have our networks, our social and family and community networks. We have our lifestyle, which is our behaviors and our attitudes towards health. And then we have things that are hereditary or biological factors that come into play. Medical care is the healthcare delivery system. And so that comes to play in that it is our access and availability of services. But when we look at this, we see our outcomes of this determinants of health are at our behavioral outcomes, our risk factors, but even larger is our quality of life and health equity. Interventions, so when we talk about interventions, these are the things that can lessen the impact of those determinants. So any programs or policies that can increase health equity and impacts on our behaviors, on society as a whole, and how it impacts us. Okay, last few things we're going to talk about are community health assessments, and then some of the I forget that those are in these. We have some weird old clip art, I think, in these that clap. Okay, so one thing that's really important is community health assessments. These are things that are now a requirement for healthcare, especially for community not-for-profit hospitals. As part of being a not-for-profit hospital, what is a benefit that the hospital gets? What do they not pay? Taxes. But for that benefit, they have to provide benefit to their communities. And as part of that, it's called community benefit, but also a requirement for all not-for-profit hospitals is that they do a community health assessment of the communities and the populations that they serve. And based on that assessment, identify priority areas for them to try to improve. So that's called a health improvement plan. We have kind of like a health assessment on steroids with the new healthcare merger, because by merging the two healthcare systems into Valid, what did we possibly lose in this community? That's important from a market perspective.
The competition.
Competition. So without competition, there's fear of what will happen.
Price gouging.
Mm-hmm. Prices can rise and rise and rise because you don't have that competition to say, oh, if I go to hospital A, it's going to cost this. If I go to hospital B, it's going to cost that. And you might not be making that decision, but health insurance companies are. And that impacts if you're going to go to hospital A or B, if it's not in coverage. But they have, because they're in two states, there's the COPA, and then there's the, I can't remember what it's called in Virginia. But both states have said, because you have essentially a monopoly, we're going to hold you to a really high standard that this is actually going to do what you said and improve the community that you're in. But so these assessments are done at the local or state level. You can go to pretty much any not-for-profit hospital webpage and find their community needs assessment. These are done more and more in collaboration because public health does the community health needs assessment as part of their role in understanding their population. So public health is doing this, hospitals are doing this. Hospitals are now systems that include all kinds of different other providers, and so they do these in collaboration. And again, these help them identify areas where they can take those resources that they are saving from not paying taxes and put them back in the community that they serve. Healthy People 2020, we talk a lot about this in the other course that I teach, but it's a 10-year plan. It's a great resource. You can see key national health objectives and kind of see where we are right now and meeting those. These are beyond just kind of your basic health metrics, but they're more integrated into prevention, health equity, and other pieces. When we talk about evaluations of health status, we do these through morbidity and mortality. What is a morbidity? I guess, what is mortality? Death, right? Morbidity are things that decrease your quality of life and your health. And so some considerations that we see are evaluating health status by longevity. And this is done many different ways. We have life expectancy, which is the prediction of how long a person will live. And then we have life expectancy at birth. And so we talk a lot about life expectancy at birth. So one of the things Dr. Wyckoff talks about, a child today, born today, is expected to live a shorter life than their parents. We're seeing a decline in life expectancy. So that is a very basic measure of longevity that we can compare across countries, across states and communities. Looking at the life expectancy, it allows you to see kind of that overall health of a community. What are ADLs? This gets at one. It's a morbidity measure. Activities of daily living, ADLs. And it evaluates 7 activities of self-care and mobility. And these are things that many of us would probably take for granted at our younger and young ages that we're in this room. They include feeding, bathing, dressing, using the toilet, transferring, grooming, and walking 8 feet. So, Mr. Youngblood, do you use ADLs?
Yeah, we do what we call a functional independence measure that measures all of their ADLs to see where they are baseline when they're in the hospital versus when they leave.
Mm-hmm. Yeah, so you'll see these used a lot in rehab, skilled nursing, across a lot of different areas.
Home health, usually what y'all run.
Home health, yeah. And then instrumental activity of daily living, which is IADLs, evaluates activities necessary for independent living. So these are, again, things that we would probably take for granted, using phones, driving a car, or using public transportation or a taxi, shopping, being able to prepare your own meals, doing heavy housework, things to like keep your house clean, taking your medication, handling money, being able to walk up and down stairs, and walk a half mile without assistance. So these are things that I think you often see taken into account when someone is in a nursing home. So my grandmother is 95 years young. She just moved from the housing, the apartments on the campus into an apartment within the main building. And with nursing homes, there's different levels of care. And part of that transition was related to her IADLs. So at 95, she's not able to do as much on her own now, and so she's now not living as independent. And do you guys use those as much?
We use them mainly to do for a home evaluation to see whether or not they're capable of discharging home.
Yeah.
But that's about the only thing. Well, yeah, we spend a lot of time with our occupational therapists. Spend a lot of time in this area.
Yeah, occupational
And
therapy.
speech therapy.
I think it's clapping because it's the last slide.
Slide.
And then we have multiple measures of utilization, which is also very important for healthcare. And so the consumption of healthcare services, or the extent in which a healthcare service is used. So the crude measure of utilization, you have specific measure of utilization and institutional specific utilization. Now, Mr. Youngblood, do you guys use these measures really at all?
We have a utilization review committee where we look at different types of services, but we don't do any specific reporting around it, so we don't dig as deep in as some other organizations. Do a lot of comparison.
Yeah. We look at, so in our evaluation of that we're doing for the statewide women's contraceptive program, we look at access, availability, and then utilization. So do women have access to these things, and then are they utilizing them? And so utilization is a different measure. So we're looking at, of the possible methods a woman could use, which ones are they using? So a certain proportion of women are using a certain kind of method versus another. So that would be a specific measure of utilization for that service. An institution-specific utilization would probably be looking at, the different hospitals or clinics within a system. Okay, that is all we have for this week, and we'll stop the recording. Everyone, don't forget to do your homework. It is due not this Sunday, but next Sunday.